two things that really drives this club and our community the way forward with the consensus. And one thing is actually the bench testing, which is very relevant for the very precise discussion of the techniques we are using. The other thing, and I think we are pretty close to be there, is the intravascular imaging, especially with the improvement done by the St. Jude system in the last 2 years, because combining the clinic with the bench testing gives us a much more higher insight in what we're really doing in the coronary arteries. Say hello to the first speaker, which would be Dr. Amabile, Bifurcation Management with image guiding in 2016, unresolved clinical needs.
Good afternoon. I would like first to thank the EBC Organization Committee for inviting me and for giving me this challenge, which is try to convince you that OCT can help the clinician in 2016 for unresolved needs. So, if we have to think about the way OCT can help us to improve our management of bifurcation lesion, I think there are two aspects in the question. The first one is, can OCT help clinicians to anticipate the complications related to bifurcation PCI? And so that involves a precise analysis of the lesion morphology. And the second point is, can OCT guide the bifurcation PCI and help us to improve the results? And we are going to see some aspect of the question involving analysis of the main vessel side branch dimension, the rewiring guidance, and the result assessment. So what about side branch occlusion? You know that is a very classical and frequent complication of bifurcation lesion, PCI. We know from previous works and the past that there are some classical angiographic predictors such as ostial tight lesion, main vessel side branch angle, and lesion length. But then OCT can provide us new information by analyzing the vessel before starting, because now we can access to the type of the plaque. In here you have an example of a lipid-rich plaque. We can also analyze the position of the plaque compared with the side branch ostium and see if there is a contralateral to the ostium side branch ostium distribution. And we are also, with the longitudinal analysis, able to analyze the angle. Last year there were different works assessing this question. Do we have new OCT predictors of side branch occlusion? And the response is yes. We can, based on these 3 different papers, we know the presence of a large lipid-rich plaque on the main vessel is a major predictor for side branch occlusion, but not calcified lesion, for example. The distribution of this lipid plaque contralateral to the side branch ostium also appears to be a predictor. Of course, a tight ostial side branch lesion analyzed by OCT and a main vessel side branch narrow angle remain predictors. So, can we also assess the side branch ostium dimension? And this is very tricky to do with angiography because most of the time there are some eccentric images and it's quite difficult to have the correct dimension. So the best way will be to perform a OCT pullback from the side branch to the main vessel, which can really give you the nice the real dimension here. But unfortunately, after putting a stent, this is much more difficult to do, and recrossing the stent with an OCT guided or without doing any predilation is very difficult. So another option would be to analyze the ostium, side branch ostium dimension by a main branch to main vessel pullback, like here. But you see that this approach is sometimes might be confusing, because here you see that when you're gonna analyze the ostium dimension by this method, you will overestimate the dimension because just the cross section is not perpendicular to the side branch analysis. So another option, a new option could be to use the cut plane analysis, which is computer algorithm that will provide you much more accurate data on the side branch dimension. And here in this paper from the Rotterdam group published last year, the authors did 2 different analyses. So they did a main branch to main vessel analysis and try to measure the ostium dimension through this, with this pullback, and they compare to the gold standard, which is the conventional analysis in the side with a side branch to main vessel occlusion. And you see that they are very different dimensions. They have different data, and they overestimate. There is an overestimation of the side branch ostium dimension with the conventional analysis. Whereas if you go for the cut plane analysis, you get much more relevant dimension, and these two dimensions are much better correlated. So this is something that we need if we want to do bifurcation. What about the rewiring? We know that inadequate rewiring in the proximal size can lead to complication in case of side branch dilation. And so we saw in the previous session that 2D and 3D OCT can help us to first identify the cell localization and the type of these overhanging cells on the side branch, 2D and 3D OCT. Here we have example of free carina type, so they're pretty good option for rewiring, whereas the connecting to carina type here with the links are not a very good option. You can also localize the most distal cell on the ostium and be able to identify the in-phase type distal cells compared to out-of-phase type. And these in-phase type distal cells are a valuable option for rewiring. So now that we have identified the distal cells, can we assess the position of our wire before starting any side dilation? And the answer is yes. Again, in this series published 2 years ago, it was feasible in 82% of the cases. And you see that that was the previous version of the 2D system, the 3D system from JUDE, and you are able to observe the wire here in the distal cell. But the results are much more dramatic and spectacular if you go for the new 3D OCT approach with this stent reconstruction analysis. And here we see that following a pot, it was much easier to cross the cell, the most distal cell, and the wire was in correct position for performing the side branch dilation. What about the identification of the early complications? Well, this is, I think, the best application of OCT, because we know that intravascular imaging can really help us to see better compared to angiographic. And here in this series of patients treated by provisional T and TAP techniques with a very good angiographic control, by performing OCT control just after the PCI, Francesco Burzotta and colleagues observed actually a high incidence of different PCI pitfalls, such as malapposition, intrastent dissection, or H10 dissection, or stent prolapse. And we know that these abnormalities can be potential contributor to stent thrombosis, so it's quite important to identify them in time, and maybe to provide the best solution in order to avoid complication. Especially because we can also localize these abnormalities within the stent and see that, for example, the stent malapposition are much more frequent in the proximal main vessel, and which requires correction. And finally, I think that OCT is also a very promising solution for the two-stent techniques in order to assess the neocarina and the struts apposition, the struts coverage, the gel ostium. Once again, it's better to do it with the new generation of 3D OCT, as you can see here, and we see that after this reverse tap, we get a very good result. But if I have to be honest, I should admit that most of the data that I presented you were done with offline generated software. What kind of OCT tools do we need as clinicians? Of course, we need relevant information to facilitate PCI. And we have now to be able to anticipate the complication rather to contemplate a result. So that's why the 3D online analysis is something that, in my opinion, is mandatory, with an easy-to-handle friendly software and some dedicated bifurcation analysis functions, and potentially also some cut plane analysis for side branch. And the good news is that this software is now available on the JUDE system, And I think the future will help us to improve our result. So that's why I think that we can do it. Thank you very much.
Thank you very much, Nicolas. Excellent introduction. So now our next speaker is colleague and friend, Dr. Francesco Burzotta, OCT with stent optimization software to support pre and post PCI decision making.
So just as an introduction, I think that the first question is, are OCT detected stent imperfections clinically relevant? This was really a question in the past, very important. Now we have some important signal. This is the CLIO PCI2 study, which is multi-center study on more than 1,000 lesions, in which the clinical outcome has been assessed prospectively, and the principal investigator is Francesco Prati. All the possible problems of the stents have been assessed after interventions, and then the clinical follow-up was clear. When you have OCT imperfection, or might be when you have OCT perfect procedures, you have a better outcome. The other point is OCT something that may be incorporated in our daily diagnostic or PCI practice? Probably the answer is that we have just to assess this, but in my lab we started working very hardly on OCT some years ago, and this is the performance of angio guidance, IVUS guidance, and OCT guidance during these years, starting from 2010. What you see, the blue bar, which is IVUS, has been for both diagnostic procedures and PCI procedures, is almost abolished and just reserved for ostial lesion. All the other assessments have been performed both during PCI procedures or by diagnostic procedures by OCT when you have DAPT by angio. And if you look at what happens when you guide, for example, your clinical decision after having assessed your procedure by OCT, this is the clinical outcome. You see that when you defer treatment of the lesion on the basis of favorable OCT assessment, you have no difference in the outcome. Is the start of FFR guidance assessment, which showed results comparable with that. But we are now here to discuss about the PCI software, which is dedicated, a software which is dedicated to PCI guidance. And moving toward the last generation software, I think that after having treated a lesion like that, in which you have a bifurcation, you have calcium, you have, two lesions, you have this result, and it might be that you want to know if is stent well expanded, is there any edge dissection, are stent struts well opposed to different vessel sizes. So this is clearly questions that are in our mind. If you use the classic OCT answer, you have to go to scroll segment by segment to assess what happens. Now we have another way, the last OCT software, which allow you just with one click to have your OCT well displayed. You have here well visualized. You have the possibility to have the red color for the malposition areas. Then you might be that you want to see how it is distributed in 3 dimensions. With another click, you do this. And if you want to know how is the stent inside, you may, with another click, go and find why this proximal malposition may hinder further procedure in the future or during your procedure. So it is another way to go and to interact with the machine very easily during your procedure. And during these months, testing the machine's ability to answer the questions, it is just the way the machine answered to questions that I had during my procedures and in my lab with other operators. Is there a stent gap? So this was acute coronary syndrome, occluded artery, which was reopened. After stenting, it was like that, long stenting, but a very complex procedure, multiple dilations. So and we implanted the 2 stents like that. This is what happened inside the software. So if you want to assess, you may just perform click, and then you see that there is a gap. And there is no doubt that it is a 36 degrees gap. and malapposition is not present. Other question, was my precise osseous stenting really precise? When we discuss in the technical forum about this possibility, at the end you may have doubt. If you want to be sure 100%, you may just push the button and then you may rotate your axis and you will find that there is no malapposition. It is really perfect placement for this stent. If you are not satisfied that you want to see, there is other tool, you move and then you scroll and then you see that the LED is really open and there is really no prolapse of stent struts. Other problems, sometimes procedures seems to be easy and then you have problems in doing this. Why problems in going through this LED lesion? There was a previous PCI in another lab in which the stent was reported to be precisely ostial. But we had a problem in going there, so what we did was to perform OCT pullback from circumflex to left main, and this is what we found. You see that there are some malapose struts in this area, and when you rotate, you see very well that the LED is completely jailed by the stent struts. So you may take a lot of time in spending balloons, wires, but when you recognize the problem, you may fix it very easily. In the same procedure, we decided to correct this in the only way I had in mind, so to perform culotte. But you don't want to have, at the end, other floating struts. So distal rewiring is performed, is checked by Angio with the two wires, the jailed wire and the rewiring wire at the carina. But if you want to be 100% sure, you may check this by OCT, and this is the quality of the images you may have. I mean, it is just a matter of using it. You don't deserve any kind of specific experience. And this was the final result. Then other question, was I able to perform a T and a small protrusion? I don't want to hinder my procedure. This was the nasty lesion we had to treat. We perform at the end TAP with the second stent into the diagonal, which was reopened. This is the fantastic result we had. And if you want to see the neocarina, you see here in red the small number of stent struts coming from the side branch inside the LED, and you may see it in this way. So very precise protruding TAP performed with the clear interpretation. If you are not satisfied that you want to be 100% sure that your LED is widely patent, you remove the wire and you go and you see now the small amount of floating struts over there from TAP. And I mean, final question, are EBC recommendations effective? So this was a LED diagonal bifurcation with small but tight lesion on the diagonal. What we did was crossover stenting with sides according to the distality, pot, kissing balloon with short non-compliant balloons. And this was the result in which, like we learned from John Ormiston with ormistography, you may see the scaffolding inside the side branch that shows that you have been very effective, and there is no red because there is completely no malapposition all over the way. So, which was the main problem during this software usage, first experience? It was during the last days when I had to export the data to you. I had to do this all with my iPhone. So sorry for the quality of the images. Thank you.
Now I would like to invite Tom Johnson. Tom, optimizing left main bifurcation, case experience.
So the first myth-truth that I wanted to dispel was the one that I hear that the left main is simply too large for OCT, and so IVUS is probably the way that we should be imaging. Now this data from Yoshi and Numa from the Trophy trial shows very nicely that of 71 left main segments that were imaged by OCT, over 2,500 frames of imaging, that greater than 80% of those frames allowed all 4 quadrants of the left main to be analysed. And that equated then actually to more than 90% of patients having adequate analysis of the left main imaging. The second one that I hear is that high flow doesn't mean you get clots. So we very commonly we'll see people land a stent across the left main and say, oh, well, it doesn't matter, it's a big vessel, high flow, we're not going to see thrombus. But I have certainly anecdotal experience of the exact opposite. This is a gentleman who presented with a 010 Medina lesion to his ostial LAD, had a stent deployed not with imaging guidance to the ostium of the LAD, and then presented to my cath lab 14 months later with a non-ST elevation infarct, with clear angiographic evidence of haziness, and then you can see on the OCT quite clearly tissue and thrombus associated with a stent that's actually hanging in the breeze within a large left main. So although it is a high flow place, there clearly is the ability for us to generate clot. And that sort of then very much is supported by the most recent data and the most exciting data I think we have by far to date with OCT, which is from the Prestige group, looking at stent failure, so looking at patients presenting with abrupt stent failure either through thrombus or restenosis. And we see that in the acute and in the subacute phase that quite clearly uncovered and malapose struts are the commonest means of presentation. But even out in the late and beyond a year phase, we see that over a third of patients have malaposed or uncovered struts. So clearly, the presence of strut not on the luminal surface covered by tissue is a mode for failure. Firstly, one which just involved a provisional approach to the left main, and this was a gentleman, very aggressive arteriopath, actually presenting acutely requiring abdominal aortic repair, and it was felt that his multi-vessel disease would be best treated by intervention rather than surgery prior to moving directly to abdominal surgery. And so we see that he has disease, mild, moderate disease in the LAD, disease in the circumflex, and a distal left main lesion. And really this first OFDI OCT run is here to show the ability of the St. Jude angio co-registration data. So here we see acquisition of the OCT in line then with the angio and OCT co-registered coming through this LAD lesion. We'll see coming back into the left main, see the circumflex wire coming in a moment into disease. And then we've been able to plan deployment of a stent to that proximal lesion, gaining distal and proximal references all online there. And so ultimately this gentleman received a stent to his LAD, stent to the circumflex, stent to the left main. That was then optimized with a pot, and we recrossed into the circumflex with a view to optimizing the left main bifurcation provisionally. And I'll just show you a still frame, and in the next case I'll show you how we acquire it real time. But quite clearly, again, as Dr. Buzzotto has shown, we get very nice evaluation of the passage of the wire across the jailed circumflex. And we've avoided the more proximal cells and made a route through the distal cell in the circumflex ostium. And that then leads to the confidence in being able to go on and perform a sequential high-pressure KISS. And we see very gratifyingly fantastic opening of the circumflex ostium with we presume, the struts then expanded out onto the lateral wall of the circumflex side branch. Now, the next case is more challenging left main anatomy, but actually in the setting of a protected left main patient. So a patent lemograph we see to the distal LAD. And actually, this gentleman had been worked up for angina and been shown on a stress echo to have anterior wall ischemia. He then actually presented in an unstable fashion and came through to the cath lab, just defining really more aggressive disease within the circumflex, but clearly distal left main extending into ostium of the LAD and a long segment of circumflex atheroma. So it was my intention from the very beginning actually to treat as a two-stent technique due to the ischemia we'd seen on non-invasive imaging in the LAD, but due to the severity of the angiographic disease in the circumflex. Balloon inflated, so predilated the circumflex prior to passage of the OCT catheter. And so we just see on this pullback really quite a small distal reference. This is only coming up at about 2 millimeters and a very high burden of disease. As we pull back a bit more, we see then significant balloon trauma. We'll come back then into the left main. There's the LAD wire. And we actually see the body and proximal left mains relatively healthy, but obviously a much larger vessel than the distal reference. And again, using the minimal lumen area, profiling software, we're able to select an appropriate stent length and size. So actually I elected to take a 2.5 stent, to slightly oversized to the distal reference and clearly is massively undersized for the proximal, and land it fairly short, and you may be critical of the fact that that's rather short for the purpose of a pot. As we see subsequently, we actually pot into the circumflex ostium. And then this is showing the real-time acquisition of 3D using, importantly, the tabletop joystick, which makes a tremendous difference to the ability to analyze and the ability to really take control of the procedure. We see here then the 3D bifurcation software being used, and what that enables is it will automatically detect each and every bifurcation along the segment and then represent it en face. So we see the bifurcation en face. There's the ability also to generate the carinal view, but we can see here as we come now to the important left main bifurcation, we have the wires in situ with the red representation of malapposition has already been described, with this wire quite clearly again passing through a distal cell strut. This is just magnifying it, and then you can see through rotation of the joystick we can see rotation of the three-dimensional anatomy, giving us a much better appreciation of the wire passage through into the ostium of the LAD. And as we sometimes, it's better to look at the two-dimensional imaging, and again, with this triple view, we're able to actually assess where we are in the three-dimensional plane and reassess where the wires are passing. Now, I had only deployed this with a 3.0 pot, and the stent rendering, the automated stent detection, is incredibly powerful, and with the ability to tailor an awareness of apposition, automated apposition measurements, we can see these red dots representing the malapposition, that we have quite marked malapposition in the left main, as one would expect, having only deployed a 3.0 balloon in a 3.5/4.0 vessel. But having confirmed that the wire passage was appropriate, move on and undertake a tap deployment just with a short stent into the LAD. And again, finish with a kiss. And now we can just look at the navigation software, again, real time, to show how we optimize that. So pulling back through the OCT, real time, we see some evidence of vessel trauma, but clearly a well-opposed stent in the circumflex vessel. And then we'll jump across to, again, the bifurcation software. So this again, using the lumen profiling software, allows us to make a very rapid assessment of the optimized stent deployment. So pulling up the distal reference to just distal to the stent, bringing the proximal into the proximal edge of the stent, and automatically we're given the proximal and distal references, and then additionally the minimal lumen area, which actually in this case falls outside the distal edge of the stent just due to the heavy burden of disease and the very small caliber of the vessel. And then we'll see we come on to the three-dimensional software. Now, there are some glitches, and here actually the second wire hasn't been registered as a wire. Instead, we see a strip of malapposition, which is actually just the incorrect detection of the wire. And again, there are some artifacts, these red dots, which suggest malapose struts, which when you look on the two-dimensional imaging are just artifactual planes of blood within the lumen. So we've already seen an example of this with Francesco's last cases. But here we'll be able to just then fly through the vessel and again have an appreciation both of opposed and malopposed struts. And again, this is all just, you can navigate this using the joystick on the bedside control, and it's all very rapidly available. And so we can then again toggle backwards and forwards through the vessel and look at the stent geometries. And again, you can see that there's an awareness of strut passage which may be opposed or malopposed, so the struts will color accordingly and just move backwards. We can then also toggle on and off the other luminal structures, so the guide wires can be removed so that you have a better appreciation of the anatomy. So here we can see this main vessel guide wire disappearing, and we'll see evidence of the misrepresented second wire down into the main vessel, into the side branch vessel. So anyway, this was the final angiographic result, and we can see in the old-fashioned two-dimensional imaging, again, a very nice expansion of the distal stent with great coverage at the level of the carina, a slightly eccentric shape to the very distal left main, but circumferential expansion in the more mid-vessel. So I hope you agree, having seen those demonstrations, that clearly OCT does play a role, and there's clear utility for both the planning and optimization. We heard earlier in the first session that quite clearly OCT plays a role both in the planning and in the deployment of stents. The combination with angiographic acquisition allows a diminishment of contrast, which has been another concern with this technology, but actually acquiring images in tandem means that the load of contrast can be massively reduced. Tabletop control allows quite clearly much easier kind of toggling between the different modalities, and allows us also to gain image analysis much quicker. And the dedicated software speaks for itself. Thanks for your attention.
Thank you very much, Tom. And how we connect this with evidence that we need to change the guidelines. It's really a privilege to have Niels Holm here to present the results of the October trial.
It's a pleasure to be here. Thank you. I have the pleasure of introducing the October trial. It's a clinical outcome trial that will perform in the Nordic Baltic countries and in the UK. I think the last sessions here we have really seen the previous speakers building the case for OCT, and I think we are now having really mature tools, and we have a lot of knowledge about how to use this technology. So the next step should be to show if it actually works. Do we improve clinical outcome using an OCT-guided strategy compared to our standard strategy? And we have designed this study here, the October trial, with a randomization of 1,200 patients to an OCT guiding arm systematic treatment protocol versus our standard guiding, where you can use optional IVUS. And then we have a primary endpoint of 2-year MACE for superiority. It's a very clean and simple design. We do not have any angiographic follow-up or OCT follow-up. We only have OCT in the OCT guiding arm. So this is a pure standard guiding arm, so you should not be teased to look at OCT images in this arm. We do include both left main bifurcations and non-left main bifurcations with large side branches, and there should be a more complex treatment protocol, so there should be a need for rewiring at least the side. We have, of course, the aim to show clinical superiority of this strategy, but it's also an aim to provide interested operators the possibility to work with OCT in a systematic way. So OCT, as we have also already seen, is beneficial, most likely beneficial in this high-risk lesion subset. We have a high level of angiographic ambiguity in bifurcations, and we have also seen that OCT identifies multiple correctable factors. I'll not go into detail to all this in the sake of time, but these are all the headlines where we can really affect and validate our procedure as it commences. So at this point, we have no strong clinical evidence. We have multiple publications on OCT and how to use OCT, but it has not been shown that using OCT actually improves clinical outcome in a strong way. We have a couple of mid-sized trials, but still we don't have any publications here that could move OCT up towards a 1A indication. Still, we have a new technology. We have many new technologies, but still OCT has entered already the guidelines just for being a promising tool and based on all the available evidence. And you have seen this slide probably before. Well, okay, OCT has been around since 2009 in a really clinical feasible way. That's 7 years we have had OCT. And we only just got the Optis Eye system with fast pullback and co-registration, all the 3D features. So this is a very young technology compared, for example, to FFR. Our primary endpoint is a composite endpoint taking into account that we treat all the lesions based on this OCT guiding strategy if you're randomized to that arm. So it's a secondary endpoint that evaluates just the target bifurcation. So it's a strategy for the entire revascularization. Then we of course have all the regular clinical endpoints, and we will have a 3D QCA evaluation of the post-PCR result, as we will not bring the patients back in again, and we will not have OCT in the standard arm. And of course we will also have a look at this, because if we don't show any clinical benefit, well, we might see that there will be an increased procedure time and use of contrast, and also increased resource utilization in the OCT arm, and that could be problematic, of course. We have a sample size calculation. We end up with 1,200 patients, and we can always debate if that is enough. If we look to the recent CLI PCI studies and the IVUS XPL, we are very encouraged, and we are quite sure that we'll be able to show with this number of patients, but it is an adaptable design, so we will have a pre-specified interim analysis to look up if it's an appropriate size of patients during the study. We have quite broad inclusion and exclusion criteria, meaning that all main vessel can have bifurcations with all kinds of main vessel and side branch lesion lengths. In almost all the bifurcation studies so far, long side branch lesion has been excluded. Most of the trials have been with 5 millimeter, and some of them up to 15. But now we accept all lengths in the side branch, and of course all bifurcations, and also patients with multi-vessel disease. So if we look at the techniques, we have, of course, one stent technique with pot kissing and pot. And then we will also, of course, have two stent techniques, but we have excluded a few of them. And then we have some treatment goals. We aim for full lesion coverage. We aim for optimal vessel and stent expansion and complete stent apposition. So these are the headlines. And to get there, we have looked at OCT, how we can use it as simple as possible, because we will be 40 centers on board this trial, so we need to simplify it as much as possible, and also to reduce the load of contrast, of course. So we will have this scheme here where you have first pre-dilatation, and then after pre-dilatation, to increase the feasibility of OCT, we'll do an OCT pullback for checking lesion preparation, sizing and positioning of stent, and sizing of the pot balloon. Then we'll go on with a stent implantation, the first pot, and rewiring of the distal stent cell. We will check that we actually got full lesion coverage, that we got expansion and position, and we will check the wire position, and excluding abdominal rewiring. After that, we'll perform casing balloon inflation and pot, and we'll check with the final pullback that we actually achieved expansion, good expansion and position, and we have a good result in the side branch ostium. If we look for the two stent techniques, we will have detailed protocols for QLOT, for T-stenting, for TAP and DK crush. The structure for treatment with OCT guided in two stent techniques is very similar from one stent techniques, but of course with that this is general principles, because OCT two stent techniques are so different. We here recommend rewiring a mid-stent cell if it's possible, to avoid abdominal rewiring of the side branch stent. And then, of course, if you have more than one rewiring, you will add pullbacks accordingly. So to teach this and to communicate this, we have developed quite extensive protocol that will be formed in posters and handouts. It will also be published very soon as in a trial paper. This is just 2 pages. It's several pages long, and on how to do this OCT guiding. What are the treatment goals? And this is an example from the TAP technique. Then you can just grab this paper and have it in your cath lab, and you can follow this, and you can see the checkpoints. What are you? So you can just tick it off that I have evaluated this. This will, of course, for some have a huge experience. In this room, there will be many with huge experience, but we will also have centers on board that has less experience. So we will have on-site training, and of course on the treatment principles and in image interpretation, in measurements, and of course also in the practical setup to make this as feasible as possible. So we'll try to make this have a very small impact on these procedures. And then we have added a next day feedback, meaning that after the procedure, the OCT and angiography is uploaded to the core lab for immediate evaluation, and then they will have, so to say, next day feedback on if they could, if the operator could have optimized it even further, both the use of OCT, but of course also the PCI result itself. This of course will only pertain for the OCT arm. This is an academic trial, it's an investigator trial, but of course it has not been possible without support from St. Jude Medical and from Abbott. We are very thankful for that. This is also a huge trial. At this point we are very dependent on the national coordinators. I know Oli Kajander from Finland is in the room, and also Indris Kumsas. Thank you very much for all your efforts in an investigator trial. The national coordinators are doing a huge job. We have quite a high number of centers that have shown particular interest, and many of them are now in the legal process, and we included the first 3 patients last week in the trial, and hopefully we will have all these centers on board within the next 2-3 months. So thank you very much for your time here. Thank you.
I can introduce myself as the co-chairman, and thank you very much for having the possibility to co-chair this session with you, Goran, and thank you for St. Jude to support the session as here in the beginning of the EBC. The key learnings from the session is actually that we need to upgrade our consensus. This is the 10 years consensus, it's 2 years back, and I basically just think that we stated that it is nice to use some intravascular imaging when you're doing bifurcations. We strengthened it a bit, but still, I think that the intravascular imaging technology is so mature now that we really can embark on more firm and more precise recommendations. But it's up to the EBC community, of course, to have these discussions the rest of the day today and the day of tomorrow. This is some of the things that we learned during the session here. What are the main points of information we can get from the technology, and where should we put it in the daily practice? We learned, and which is the most important thing, that this new software facilitates a real-time analysis. I think most of the presenters showed us pretty well that it's easy when it's integrated in the cath lab to conduct the evaluations and do the calculation online by the operator in sterile environment. And of course, for the bifurcation, it's a dedicated software. I think we just have to highlight some of the information we just got. What is new in the software? Well, it's a stent roadmap, which is a co-registration from the angiogram and the OCT, which makes it transferable directly. There is a position indicator. There's a 3D bifurcation mode. There's expanded 3D navigation. And there's also, which is much more important for the bifurcation club, automatic detection of side branches throughout the OCT evaluation. And of course, it's durable, and it takes only few minutes to get the information in the cath lab. So it seems that the technology is mature enough to promote a more broader use. How should we use it then? This is just a kind of a brainstorm for the discussion we need to have of where to go with the consensus statement, but it seems to provide clinical benefit, at least to have access to intravascular imaging during elective left main PCI and in other bifurcation. So it seems from the literature and the case reports that we gain more information and we have a more secure feeling of a more proper done job while we finalize the procedure if we have seen these imaging It seems also to provide clinical benefit to use multi-step guidance and technical result verification when we require 2 stents. And at least it seems very highly useful in BRS bifurcation implantation. We have not been discussing that much in this session, but of course it would be an area where it could be promoted. Again, consideration to keep in mind for the rest of this meeting. Have it in your mind and try to, well, see where we can fit these recommendations in the new consensus. We could argue that it is recommended to use intravascular imaging if a complex LM, left main PCI, don't go smooth. It's a softened thing, but if you feel tension on the wires, if you think that the procedure don't really move forward the way you're thinking, it could be an option to use intravascular ultrasound to get a precise evaluation of what is actually going on. Are you behind the struts? Or is it a technical issue with protruding stent or other things? It is recommended to have access to intravascular imaging when doing elective left main stenting. It could be, at least for the patient view, maybe a good thing to promote. And it is encouraged to use intravascular imaging during BVS bifurcation stenting. And I think that would be some of the issues that we could end up with. So I think this new technology have an extremely good platform for strengthening the consensus on how to use intravascular imaging. Again, this is the last slide. Just remember that when you have a tapered vessel, you will have gaps in the proximal part, and it's very easy to go behind without seeing anything in normal angios. So we need intravascular imaging to really get a feeling of what is going on if a procedure don't go smoothly. And having said that, I would finalize this procedure by thanking St. Jude once again to make it happen and to being a gold sponsor in this setting. And thank you for having this happen. And thank you for the presenters and my co-chairman. And this was this session.